Elias, can you talk a little bit about how frequently you monitor for mutations and when you check for them?
Well, I check them at the beginning of therapy, and then if they're responding, I don't check them again. What matters for me, the response. If this patient 359 mutation, I start them on ponatinib, and then in 3 months, your PCR is down to 1%. Anyway, there's no room for Sanger sequencing anymore. You can use other techniques, but we don't have the evidence that they will help. So I will only check for mutations if I don't have a response. Somebody in whom I have a diagnosis of mutation and doing well, I will not do any mutation testing anymore.
And for this patient now with a T315I mutation, is this a patient that you start working up for a stem cell transplant?
Well, anytime I have somebody who's failing therapy, mainly second-gen TKI, I want to do the workup for a transplant, looking for a donor. It doesn't mean I want to go for transplant. And in fact, I can tell you if I see this patient in the clinic, which I saw somebody yesterday, who's a young man, a lawyer, he's telling me, give me anything but transplant. So we're going for asciminib and other new drugs. So I will type this patient for transplant. Of course, I will make sure I have a donor. And then I will start ponatinib. If I have a very good response to ponatinib and BCR going down to 1%, and maintained, I will put transplant on hold. If I don't have a good response and my PCR is going up or losing my response, then I will go for transplant. But I think in chronic phase, there's data comparing from the PACE trial to the EBMT registry. In chronic phase patients, with 359 mutations, ponatinib seems to be better than transplant. Of course, these are not randomized trials with all the caveat of the comparison with historical data, but I think we know from the PACE trial that responses to ponatinib are durable. If you induce an MCYR at 3 months, 80% of these patients maintain the response, and therefore I will not go for transplant even though they're a younger patient.
Had the patient had a bone marrow biopsy at the time the white count was 140,000, and they were relapsing on frontline therapy, and they had blast crisis. Tell me how that might impact what you'd be thinking about after you put them on ponatinib.
That is totally different scenario. So I mentioned transplant for chronic phase. Of course, if transformation to blast phase, I will not use ponatinib as a single agent. It does work. We have a good responses, but they are short-lived. For this patient, regardless of the mutation, I will have used a combination of chemotherapy and ponatinib. If it's a myeloid blast phase, I will use AML regimen. She's a young woman. I will use flag either ponatinib, and I will go for transplant.
Michael, is that what you do in New York?
I was just thinking what a dotted line we have between 15% blast and 20% blast. So that's why I said there were a lot of alarms ringing with this case. And I think with careful monitoring, I think if they still meet criteria for chronic or accelerated phase, single agent TKI is reasonable. And you should see the outcome relatively quickly. Hematologic remission, any cytogenetic or molecular improvement relatively quickly. But I think you need to be careful that a blast phase patient, A, needs different therapy, as Elias just mentioned, and B, is very likely to fall back into blast phase again and needs to move on. So transplant.
And they won't maintain them with ponatinib post-transplant, not only offering transplant, and then it's one-time event, so just maintain them on therapy.
And Elias, can you talk about where you might use omacetaxine?
Well, it's a very unfortunate drug. Every time this drug was close to an approval, we get other compounds, oral drugs. Omacetaxine is approved today for patients who failed 2 TKIs. And the way it's given, it's 1.25 sub-Q twice daily for 14 days induction. And then during consultation is once a week. I think at this dose it's quite myelosuppressive. We've seen around 10% CCYR. So I think between ponatinib and omacetaxine, I'm more in favor, of course, of ponatinib. Now, that being said, I use omacetaxine usually in combination, not a single agent, in blast phase where I have no other options to be given. But I think in chronic phase, I'm not quite sure where to fit this drug. Especially, and if when I use it, I will use it for 3 days, 5 days max, not like 2 weeks as it's the label, because of the myelosuppression. You get platelets single digit, they will never recover for 4 to 6 weeks.
It is an interesting drug because it does have activity against T315I compared to all the other TKIs, but it is truly a chemotherapy drug. It's delivered like a chemotherapy drug in spirit. It's myelosuppressive. You get into the same kind of myelosuppressive related problems with it. So it is a drug that we've been hesitant to use outside of the setting of blast crisis, and we do use it there when we have other limited options at that point.
You know, one thing about patients who failed TKIs, age is a factor. So if you have somebody who's 80 years old, on TKI, even if I don't have the magical MMR or things, even if they have a partial response, I tend to keep them on TKIs. Don't take them off TKIs, put them on hydroxyurea, keep them on TKIs, and let them be.
Yeah, I mean, that situation of maybe inadequate response or partial response in the patient who may not have any other options. I think Brian Drucker, my mentor, always said that the same thing. It's TKIs will always do better than Hydrea over the long term, even with just hematologic response.